Hello, Dr. Kim. We are ready?
Yeah.
Okay.
Yeah, you are ready?
Yeah. Would you introduce your team and case?
Okay. Welcome to Senior Hospital live session 2. I'm H.S. Kim. My co-operators are Dr. Han Jung-gyu, Dr. Yang-an Mo, and ENCORE specialist Dr. Park Jun-bin, and many fellows and staffs. Slide, please. Let me introduce my case. This 73-year-old male complained of exertional chest pain. After visiting Asa Medical Center, he was diagnosed as severe AS and SAVA was recommended. For a second opinion, the patient visited SNU Hospital where SAVA was once again recommended. However, because of his bad memories about his mother's post-operative pain after open heart surgery 20 years ago, he strongly refused the surgery. Meanwhile, he got to know about less invasive TAVI through the internet, and he visited me to receive TAVI. Plus, aggravating chest pain and dyspnea is the issue for this patient. Plus, we are going to do a TAVI as he strongly wanted. Plus, a risk is low surgical risk. SD score 1.7, lowest Euro score 6.4, low or intermediate risk patients. Plus, chest X-ray, a little bit cardiomegaly, ECG, first degree AV block. That is one factor to determine the valve type. Plus, TTE, LVH, tricuspid AS with mild AL. Plus, TEE, mean pressure gradient is about 50 total. AV area is 0.78 square centimeters. Tricuspid AS with mild AL. Plus, root autography shows the best angle is around AP view. Less calcification, good anatomy of coronary ostium. Plus, coronary angiogram shows insignificant lesions. Plus, thoracoabdominal iliofemoral artery CT angiogram shows mild calcification around vessels. Plus, moderate to mild calcification distributed equally to the three cusps. No LVOT calcification. Plus, coronary height is sufficient, 13 on the left, 18 on the right. Plus, right iliofemoral artery, good. Bifurcation is very low. There is spot calcification around puncture site. Plus, left iliofemoral artery is good also. Plus, both iliofemoral artery angiogram shows good. Plus, to summarize the measurement of dimensions, annulus perimeter is around 83 millimeter, while annulus area is about 560 square millimeters. Plus, when we choose SAPIEN3, 29 millimeter valve would be appropriate with 17% oversizing. Plus, when we choose Avatar system, 29 oversizing index is about 7% insufficient. Thus, 31 oversizing index would be 15%, but it's not Avatar, core valve. Plus, thus I prepare 3 issues to be discussed in this case. Which valve should be used and why? Are low-risk patients really low-risk? Expanding TAVI to low-risk patients? The first issue. Plus, there are several clinical conditions that favors one specific TAVI valve among 3. Risk of AV block, RBBB, and first-degree AV block on ECG, and horizontal heart favor SAPIEN3. Risk of dissection due to small tortuous aorta, risk of coronary obstruction due to low height, shallow sinus, favor Evolutol. Risk of leakage due to annulus calcification or tear due to alveolar calcification, favor Lotus. Patients has risk of AV block, first AV block, and a little bit horizontal heart. That made me select SAPIEN3 for this case. Plus, conventional risk prediction model is dependent on STS score, Euro score. That includes just comorbidities. But frailty and disability are not considered. As shown in the slide, slow gait speed is a predictor of higher mortality of the TAVI. Plus, therefore, there need for a better prediction model in traditionally low-risk patients, including frailty, disability markers, or BMI, COPD, liver disease, coagulopathy, that are already proven to be important risk factors in TAVI trials. Plus, there are ongoing efforts, Notion 2, Partner 3, CoreWeb low-risk RCT, to test TAVI in comparison with SAVI in low surgical risk patients. In any way, we decided to do TAVI using SAPIEN3 with 17% oversizing index. Let me show you the angiogram that we taken today. Angio, please. Usually we perform puncture under angiograph guidance plus root autography shows the good projection angle, AP plus AP caudal 5, good. Less calcification. 17% oversizing index would be appropriate. Regarding the fixation or leakage, plus advanced sheath, plus advanced wire through the AV, plus and advanced catheter, plus exchanged wire with curved wire, plus advanced pigtail catheter. Okay, then we check the pressure gradient between two chambers, left ventricle and aorta, about 40 millimeters of mercury peak pressure difference. This is what we have done today. And from now on, I'd like to do implantation of SAPIEN3. So recommended range of oversizing by Edwards is about -5 to +20%. In my experience, oversizing index, either oversizing index is about 10 or 15%. Because of the low volume in Korea, several global studies offered participation, but finally they just gave up because of the low volume in Korea.
I think
so oversizing the 17% is too excessive. Then we have to consider just 0.5 cc on the field. How do you think about on the field or nominal volume inflation? Okay, we are going to do 0.5 cc on the field. That leads to oversizing index down to 15% from 17.7%. 15% oversizing by 0.5 cc on the field.
Okay,
Can you see the T to show that most panels are concerned about the LBOT bulging septum. T large 이미지로. Is there bulging septum severe?
There is a little bit basal septal hypertrophy, but
LBOT?
I think it can be acceptable.
아orta valve 보여줘야지.
네.
I think this one is very good for us. Immediately and simultaneously, some imaging specialists comment about using a TEE.
Yes.
Okay.
I think there's still some space there. But
I think
maybe you
180.
should implant higher.
Okay, off. Then we are ready to implant a valve. Just 10 minutes left. 픽테일, T 빼고, 자, advance. 네. A little bit higher implantation. 자, test once again. Okay, just 준비. Pacing. Die. Inflation.
하나, 둘, 셋, 넷, 다섯 끝까지 갑니다.
Okay. 1, 2, 3, 4, 5. Deflation. Pacing up. To avoid the wire bias, I little bit pull the wire to be located in center.
Anyhow, the
Blood pressure is good. Pulse pressure is very narrow, suggesting no leakage. T.
First, there is no significant probable regurgitation as shown in this short axis view.
약간 카우달. Okay. Minimal leakage at around 12 o'clock, even though there is 15% oversizing. We already perform 15% oversizing, and as you showed, EKG, you can see the LBBB. Thus, it is not necessary to do adjunctive ballooning. We already perform oversizing index more than 15%. There is LBBB. Thus, I exchange the wire with pigtail catheter to more accurately assess the regurgitation, to check the angiogram, then decide to do additional ballooning or just finish. Most priority is angio with large amount of dye in the low position of pigtail, not high, small dye injection. Okay, as you can see, the hemodynamics, pulse pressure is very narrow, suggesting probably no leakage. Pressure gradient is disappeared. And simultaneously, we can see the LBBB. How about the length of PR interval? A little bit longer, prolonged. In any way, there is a conduction maintained. It's good news. As you can see, the air index is about 40. Hemodynamically perfect with 15% oversizing. Okay, let me
your
show
procedure.
you the arterography, best angle. Okay, let's see once again TE, because we have time. Is it due to the leakage, valvular leakage due to pigtail on side, or paravalve leakage? Don't mention about that.
Okay.
We all know. Just please listen.
Please, his
It's
comment
out of
about
range,
the imaging.
eh? Dr. Hong, it is out of range. Okay? Okay, 12 o'clock, spotty, lunge section. Color. Once again, we also see minimal leakage around the upper side. It's a very clear image of TE because we recently launched a very sophisticated imaging system. Thus, AR index is about 40, perfect, but there is a subtle Doppler signal, and we cannot interpret the angio image because there is a pigtail in situ. My plan is to wait for about 15 minutes, then expand the outward skirt of SAPIEN3, then see the T once again. And if there is less leakage, then I withdraw the pigtail and see the root arterography to exactly assess leakage with root arterography without in situ pigtail. Okay, welcome again, SNU Hospital.
Okay, 20 minutes waiting, so your lesson.
we waited for 45 minutes. As you can see, the pressure profiles does not change. Narrow pulse pressure of aorta, no pressure gradient is good. LVEDP. Angio, please. This is aortography immediate after implantation of a valve with pigtail in situ. Plus, this is interval angiography, a little bit changed. Thus, when you can see the regurgitant direction, that is more coincide with the pigtail catheter. Okay, T, please. Briefly, the trivial minimal regurgitation a little bit declined, but there is two spots around 12 o'clock. It is very interesting because we matched the finding of CT slideshow. Here, that leakage point is border between non and the left cusp. There's very interesting distribution of calcification, non and left. In between, there's some cleft after implantation of SAPIEN that is not perfectly sealed with outskirt. Thus, I think we already perform 15% oversizing plus, and EKG shows pre-TAVI, first degree AV block, after TAVI, LBBB. PR interval changed from 99 milliseconds to 130, and QRS interval is 150,
200, from 200 to 200.
150 to 200. Thus, if you perform additional balloon with overfill, that may lead to complication of complete AV block.
I think so.
Thus, from now on, I'd like to remove the ventricular pigtail and reassess the regurgitation with angiogram. Temporary pacemaker, in case of LBBB in SAPIEN situation, I keep the temporary pacemaker for overnight. Then next noon, I decide to remove or not of temporary pacemaker. In this case, I expect there is no further aggravation. Usually, in the worst case of SAPIEN, the conduction delay progress worsens for about 3 or 4 days. But I guess we can remove the temporary pacemaker tomorrow noon.
So
in case of Avatar, when LBBB happened, then I would be more cautious in determining the removal time of temporary pacemaker because of sustaining outforce of Avatar. I prefer the tangential projection to see the actual depth of TAVI valve. This is view from anterior plus view from left side plus view from right side. There's still a minimal
I think it's one.
leakage that may be proposed by, constituted by the paravalvular or probably transvalvular in early phase after kind of removal of the wire pigtail catheter. 1,100.
We normally use it at 600.
600, okay, 600.
will be okay.
Yeah, normally we give about 10 for 20.
In some
So
600
I always
PSI.
make
In a live
leakage more dramatically because of the pursuit of complete
네.
In a live
600.
case, people use 500, you know.
Or use dilute
It's very
contrast.
low injection volume, and then repeat angio. Slide. To summarize
Congratulations.
the case, this is low-risk patient. Thus, I'm really concerned about perfect results because low risk. SD score is just less than 2%. Rogers Euro score 6.4%. That is low risk or intermediate risk patients. And I chose SAPIEN3 29 millimeter with 17.7% oversizing. concerned about safety or it will be conduction disturbance, we actually inflate 0.5 cc on the field, leading to 15% oversizing. In such kind of oversizing index with SAPIEN3, I've never seen leakage, but I've seen leakage, trivial, because it's very interesting position of calcium chunk between L and non-CC. But anyway, it is minimal because AR index is good, and it's very good resolution echocardiography shows just 2 separate pinpoint regurgitation around noon o'clock. LBBB disturbed me to further aggressive adjunctive inflation, but that will be soon resolved if the patient has luck. If the patient has not LBBB and the oversize index is just 10%, how do we do? Adjunctive ballooning? In our analysis, Dr. Junbin Bak submitted a paper. The message is like this. If the calcium is concentric, we can cure it with additional ballooning. But calcium is very eccentric. Leakage cannot be improved by additional post-ballooning. In this case, we can see the 12 o'clock, there is a certain thickness of calcium echo that corresponds non-CC on the left, 11 o'clock, LCC on the right, 1 o'clock. Exactly that point is the leakage. Even though we perform oversizing by 70% with adjunctive ballooning, it is less chance to seal the gap between non and left cusp. I expect minimal leakage on the cleft between 2 calcium chunks would be decreased in the future because of the position of fibrin material and the thrombus. Thus, I don't expect such kind of minimal leakage would progress. Yeah, mild to moderate degree leakage should be corrected on site, but minimal leakage has high probability to regress during OPD follow-up in our experience. Thus, I don't do anything further. But the interesting message is even there is a subtle calcium unequal distribution through on the non and left coronary cusp may induce such kind of minimal leakage. We expect the perfect results because calcium amount is not so much. And we chose a bigger valve, oversizing this 15 or 17%. That valve has outskirt to prevent leakage. But we cannot abolish the leakage because of subtle, interesting distribution of eccentric calcification. Oh, no more maneuver. I'd like to finish the procedure at this stage. I'm satisfied at the final results, and I really get another kind of learning point from this case. Even though it is very favorable anatomy of aortic valvular complex, but subtle distribution of calcium may induce such kind of minimal leakage. It's a very interesting case.
Okay, congratulations on the excellent result. Thank you for your devotion and your beautiful TAVI procedure. Thank you.
Okay, bye-bye.